Hi, everyone. Welcome to today's webinar, Medicaid Under Threat, New Rule Cuts Protections for Enrollees. Before I get started, I do want to let you all know that this meeting is being recorded and that the slides and the recording will be available on Families USA's website following today's event. I'm Melissa Burroughs, the Associate Director for Strategic Partnerships at Families USA, and I'll be moderating today's session. Today we will cover the new Center for Medicare and Medicaid Services federal rule that weakens maintenance of effort protections for Medicaid enrollees during the public health emergency. We will explore the implications of this new rule, which, among other things, allows states to cut Medicaid benefits without losing their enhanced federal funding, and discuss how advocates can take action. Next slide. I'm joined by a star-studded panel today. First, you will hear from Joe Weissfeld, Director of Medicaid Initiatives at Families USA, and he'll provide us with an overview of the interim final rule and its implications. Next, you will hear from Amber Christ, Directing Attorney at Justice and Aging, who will discuss the implications of the interim final rule for California and other states, drawing on her own experience in the state of California. And then you will hear from Cuello, the Director of Health Policy at National Health Law Program, and he will cover the implications, the legal implications and advocacy strategy related to reacting to this rule. And then finally, I will close us out with the what we can do, a call to action, additional resources, and open it up to questions. So we will have questions at the end, but if you have questions throughout the presentation, please feel free to drop them into the chat box and we will get to them at the end of the presentation. So with that, I'm going to go ahead and turn it over to Joe.
Great. Well, thank you so much, Melissa. I'm excited to be here and to talk about this important rule. So I'm going to kick today's conversation off, like Melissa said, with an overview of the maintenance of effort policy, what it is, how it got implemented by CMS, how it got reversed recently by the Trump administration, and what it all means going forward. Next slide. So let's start at the top. In March, the Families First Coronavirus Response Act, or Families First, as a lot of us know, as it's referred, was passed into law. So that happened in March, and a key provision of Families First provided enhanced funds for state Medicaid agencies. Again, a lot of us knew about that enhanced 6.2% FMAP bump, or federal matching assistance percentage. And a lot of us also know that there was a stipulation that came with that enhanced FMAP that said that states contingent on receiving those enhanced match funds, that they were required to do a couple things, 4 things in fact, and those show up on this slide. The first one is the one we'll spend most of today discussing, but I think it's important to understand all 4 of the requirements that showed up in Families First. So that first one is around eligibility, and a lot of today will refer to that as MOE, or maintenance of effort. And what that said is that states have to maintain eligibility standards, methodologies, or procedures that are no more restrictive than what was in place in that state as of January 1, 2020. So that's the one, that's the MOE legislative language. We'll talk a little bit about what it means, how it was interpreted in a little bit, but just to lay out what the legislation said, maintain eligibility standards, methodologies, or procedures. The next couple are a little bit more straightforward. Premiums. States can't charge premiums that exceed what was already in place as of January 1, 2020. Pretty straightforward. The third one, around cost sharing for COVID testing and treatment. States have to cover testing and treatment for COVID without cost sharing. There you go. Again, pretty straightforward. And then the last one is the continuous coverage requirement. Again, this one I think a lot of us know about. Can't terminate individuals from Medicaid once they've been enrolled as of the beginning of the public health emergency or subsequent to the emergency. and there are only exceptions to that is if someone has voluntarily has to be removed from the program or is no longer a resident of the state. So again, those are kind of the 4 requirements that show up from the legislation. And that first one, that eligibility or MOE one, is going to be the primary focus of today's conversation, largely because of CMS's reversal, but we'll get to that again in a moment. But it's important to also note that number 3 and number 4 also have been rolled back to some degree because of Trump's administration. So before we get to that portion of it, let's go to the next slide and actually talk about how CMS interpreted the legislation, because it's really important to understand that, because this, again, is a really complicated process. After Families First came out, CMS came out with a number of pieces of sub-regulatory guidance to help states and providers implement just this portion of Families First. Those 4 requirements required 3 different series of FAQs from CMS. In April, they released a 19-page FAQ that was followed by an FAQ in May that was later folded into another FAQ in June. And that June one was a 99-page FAQ. So it just really shows that there's a lot going on to implement just those 4 couple things. But going back to that MOE requirement, that first eligibility requirement, CMS interpreted that eligibility requirement as protecting benefits from cuts on the principle that a benefit cut is effectively a reduction in coverage or eligibility. So they really went out of their way to say that benefits cannot be cut during the public health emergency. And this slide shows that twice here, and where in the guidance they said that. So you can see in that middle column, bolded, where they say states may not reduce benefits, states must maintain the eligibility and benefits. And when we share these slides afterwards, you'll be able to pull the exact quote where they highlighted this in their guidance and the date. But it's not just that benefit side. They also went further and interpreted cost sharing under a very similar principle. They said effectively that that cost sharing was protected under that same principle, that it would convey a reduction in medical assistance, so that they said no to cost sharing reductions as well, that increasing cost sharing to individuals would also put them at risk for losing that enhanced match. So again, no increase in cost sharing in order to keep that enhanced match. So when CMS came out with this guidance, very strong guidance on that maintenance of effort provision and ensuring that states got that enhanced match, which we feel very strongly about, and in fact think that states should get even more. We'll talk about that later, but in exchange that they were protecting those benefits for beneficiaries across states. Next slide. But this all changed last month. So in a reversal of that guidance that we just talked about, from that legislation that came out in March and that guidance that came out in April and May and June, on November 2nd, the Trump administration released an interim final rule. And it's important that we know that it's an interim final rule, which we'll get to in a second, that it's going to weaken these protections for millions of Medicaid beneficiaries during COVID-19. So, if we walk away from this webinar with 4 things, it's going to be the 4 things on the left side of the screen here. So first, this rule was effective immediately. So on November 2nd, it took effect immediately before there was even any public notice or comment. So immediately, this reversal took effect. Second, it reverses and undoes the protections on benefits that had been in place since the beginning of the pandemic that we had just talked about. It's going to allow states to make cuts to coverage without losing that increased FMAP, and it's going to undermine some of the COVID-19 response efforts that were in place that allowed states to really address COVID-19. So I'm going to dig in a little bit about each one of those quickly, and then our other panelists are going to go into these into even more detail. So first, I think the biggest one in from my point of view is it's going to allow states to cut optional benefits. These are things like oral health care for adults, home and community-based care, substance use treatment. As we head into state legislative sessions, and many states are facing very tight budgets, as many of you know, this will be very attractive options for some state legislatures, and it will jeopardize the health of tens of millions of Americans. The next one, CMS is now saying that states are going to be allowed to increase cost sharing. And so this is going to allow states to put more dollars and burdens on financial burdens on the back of individuals who rely on Medicaid to access care, again, during an economic and public health crisis. Again, we're taking away protections that were in place previously, something we are not happy about, and again, unwinding some of those protections that were in place. The next one, I'm going to give a little bit of the high level, but it's probably one of the more confusing ones. This one's a bit of an end around that will permit cuts to coverage by transferring individuals to different eligibility categories with less benefits. So we'll probably talk about it in the Q&A a little bit, but the process more or less will allow individuals to be moved from their current eligibility group to a new eligibility group, even if it means it's a reduction in benefits. So this contradicts that initial slate of guidance that said no reduction in benefits, and it's a bit of a convoluted set of a new set of tiers of coverage, which is what CMS is calling it. And this is in response to state government concerns that individuals may be no longer eligible for certain eligibility groups and some of the costs associated with it. But the rationale for the way CMS set this up is basically saying that a benefit loss is really not a benefit loss, and it's just a really confusing process. So effectively here, what you should know is that an individual could lose benefits by being transferred to a new eligibility group that just has less benefits in that eligibility group. So I'm sure we'll come back to this one more, but more later. The next piece here that we'll talk about is related, which is this new tiering system that CMS has come up with has the effect that it could allow the elimination of COVID-19 treatment for certain people in tiers. And so individuals that are in limited benefit plans, like family planning in some states, might not be able to be eligible for COVID testing and treatment. And cost sharing protections for certain eligibility groups might not be there going forward. So again, it's just an additional reduction in benefits and protections that may happen because of this rule. And the final one that I wanted to highlight is that this new rule gives states a potential workaround to terminate coverage. So that was that number 4 option on the first slide, where you have that continuous coverage requirement, where states could only terminate coverage if it was voluntary or when a state was no longer, an individual was no longer a resident of a state. This rule expands that and allows a new definition around someone being, quote unquote, not validly enrolled. And so there are some processes around whether someone has committed fraud, abuse, or whether the agency has made error. And so the fraud and the abuse side, the rule defines, but the agency error side, they don't. And this gives a bit of additional discretion to the state to decide what that means. And that could lead to additional abuses like we saw in states like Missouri and Texas, where they abused some of their administrative authorities. So I know that was a lot on the slide. We'll paint a little bit of a clearer picture of what this might look like throughout the presentation, but really wanted to just give you an overview of what this rule does. So let's go to the next slide. So the last part of the rule that I think will be really helpful as we talk about the comment period is that CMS acknowledged that this rule actually could hamstring states' efforts to respond to COVID-19. So this quote, I think, is something that people should look at and use when they do submit their public comments. And I bolded the last part of this, which says that CMS acknowledges that it could undermine states' COVID-19 response efforts during the public health emergency. So we should be very readily available to remind CMS that they said this. So let's go to the next slide. All right, so what does this all mean? So I just wanted to start at the state level really quickly because since there has not been federal action to shore up Medicaid since Families First, state budgets are hurting, and we should be honest about this. And in this slide, we can see, and we'll talk about it in a second, the rapid increase in Medicaid enrollment. Medicaid has been a saving grace for millions during this public health crisis and economic downturn. And states like Utah, where expansion launched right before the pandemic, tens of thousands who would have otherwise been caught in the coverage gap have been enrolled in Medicaid. This is great. So yes, states have seen sizable increases in enrollment, but it's been so important for the health and financial security of millions. So we've been tracking Medicaid enrollment trends since February, and this has been a major part of the conversation because of that continuous coverage requirement. So we've been tracking this, and this slide shows state enrollment data across 41 states across the most recent reported month. And on average across these states, we see about an 11% increase of Medicaid enrollment. For reference, when we look at 2019 over the same time period, the enrollment increase is negative 1%. And only 6 states saw over a 1% growth. So by comparison, 11% growth is huge, absolutely huge. And this is almost 7 million new Medicaid enrollees that are being covered because of this public health emergency. So this is covering a lot of people. But it also means that budgets are going to be tighter because these are states that are picking up the slack, and the federal government has not provided additional support. Just because it's a little bit smaller on your screen, I'll just highlight that Utah has seen the highest growth here at 23%, California the lowest at 4%, although that's still over 500,000 people, and that 29 states have seen over 10% growth during this period. Next slide. And with just my last slide, which will lead into Amber, what this really means is that leading into these legislative sessions, states are going to take action. And with the reversal in this, the Trump administration's guidance with this new rule, it's going to allow states to do more than they previously could. So before, really their only option was to cut provider rates. That was allowed during the public health emergency. It continues to be allowed. Historically, one of the other options was to speed up redeterminations to increase terminations. That was not allowed previously. It continues to not be allowed. But the other option that historically has been on the table that was previously banned, but is now back on the table because of this interim final rule, is to cut optional benefits. And so this is one that worries us a lot. And I think our state advocates are going to see this a lot going into state legislative sessions. So I'm going to pass this back to Melissa, and I'm sure Amber is going to talk a lot about that last piece. So Melissa, I will pass it back to you.
Thanks very much, Joe. And I'll just turn it right over on to Amber, who will talk about the implications for this rule in California specifically, particularly related to some of those potential cuts, as well as some other things. So Amber, go ahead and take it away.
Thanks, Melissa and Joe. So my name is Amber Christ. I'm a directing attorney at Justice and Aging. My pronouns are she, her, and we're a national organization working on behalf of low-income older adults, but we do a ton of state-based advocacy in California. So next slide. California, I think, is an example of what states could start to do under this rollback of the maintenance of effort protections that we've seen in place. And this was something that Governor put in place in May of 2020 after COVID took what was a pretty generous January budget in the state of California, and recognizing that California would have a lot of budget constraints and was losing revenue quickly, the governor put out a proposed revision to his January budget in May. And that revision had significant and deep cuts to a ton of programs. And most notably, as Joe noted, these were the optional benefits under Medicaid that the governor was proposing to cut. And by optional, that means that state Medicaid programs have the option of covering them versus mandatory or required benefits under the Medicaid program. But optional does not mean that they're not essential benefits. And in particular for us, as advocates for low-income older adults, these cuts, these benefits that are considered optional really impact older adults. So I'm just going to focus a little bit of time on discussing the specifics of California's budget, which proposal, I want to make very clear that it was a proposal. There was a proposal to cut oral health and to reinstate 2014 dental benefits, which would have meant cuts to benefits including root canals on back teeth, partial dentures, and periodontal treatment. So in total, 8 million adults in California's Medicaid program would have lost those services, which of course for us, those are services that older adults in particular rely on, but are also services that without individuals are more likely to be hospitalized or have their teeth extracted, all things that you do not want to see happening during a public health emergency. The governor also proposed to make deep cuts to home and community-based services. So these are the services that provide care to people in their homes and in their communities so that they do not have to receive care in an institutional setting. So they're not forced into nursing homes. So really critical benefits at all times. Again, though, during a pandemic, absolutely fundamental benefits to have in place, especially recognizing how risky it is to be in a nursing facility right now. So the proposal included entirely eliminating 2 of the home and community-based service programs in California, the adult day health care program, which is called community-based adult services, and an intense case management program for individuals 65 and over who need intense case management to stay out of nursing homes, called the multi-purpose senior services program. It also included cuts to our personal care program called in-home supportive services, so it was going to reduce hours by 7%. So in total, 46,000 older adults and people with disabilities in California would have lost access to HCBS services entirely, and another 625,000 individuals would have had their personal care hours reduced. So next slide, please. We kicked into gear. First, we formulated what a bad policy and how bad these cuts would be from a policy perspective and in people's lives, what kind of harms would happen. And we started off with you cannot cut health care during a pandemic. And you really cannot cut health care in a pandemic to individuals who are at highest risk for serious illness and death during the pandemic. So older adults and people's underlying health conditions represent 80% of all deaths. And it's really communities of color that are being harmed the very most, with death rates at rates 2 to 3 times higher than white older adults and people with disabilities. And then it's the Medicaid program that is the program that is predominantly serving this population. And not only that, we argued that you could not, that this would lead to increased institutionalization. By cutting these home and community-based services, you were putting people at further risk of going into a nursing home, which would lead to just an increased risk for death or serious illness. So not only was it the harm that was happening, but there's also the legal argument that you were violating, or the proposal violates Olmstead, the Supreme Court decision that said that services should be provided in a least restrictive setting under the Americans with Disabilities Act. So we made all of these policy arguments, and then finally, but not least, we argued that they were at risk of forfeiting federal funding by implementing these cuts, namely that they would be violating the Families First maintenance of effort protections that Joe just described. So we kicked into gear, the next slide. Making these policy arguments, we built out coalitions working with aging and disability advocates, healthcare advocates, equity advocates, legal services. We worked with California's Oral Health Network, the National Oral Health Network, home and community-based service providers, and then national advocates and coalitions like Families USA and others. Next slide. We did education, webinars, fact sheets. You saw in 2 slides ago 2 fact sheets that we worked on, one in partnership with Families USA, on how the cuts would impact older adults and people with disabilities. We did massive teletown halls, letter writing, legislative virtual visits. We did public comment. We made calls to the governor and scheduled meetings, days of action, and we got really local, working with local county boards of supervisors and city councils and local legislators to convince the governor that these cuts should not be implemented. Next slide. And in the end, they weren't. There were no cuts to any aging and disability programs in the final budget. And I can confidently say that all of the policy arguments were those that were ones that were the reason that the Families First legislation in the first place have those maintenance of effort protections in place, is that those MOE protections are there to ensure that during this public health emergency, people do not lose access to health care. And that all of the policy arguments we made were to that end, but it was really the maintenance of effort protections and combined with with maybe that there could be additional federal Medicaid increases, that the state of California said we won't make these cuts. I think that it was because that MOE was in place that ultimately California did not try to move forward with making these cuts because they would risk losing that federal funding. So for for the MOE protections to go away now means that states can start to do exactly what California was proposing to do. And as Joe noted, there are so many states facing really huge budget shortfalls that they will turn to cutting those optional benefits for folks. So we are still doing ongoing advocacy. Obviously, we are commenting on this MOE. We're still doing increased advocacy to get increased funding to Medicaid programs in the states so that they have enough federal funding that they don't have to make any cuts to their programs. And then we're also working continuously at the state level to raise revenue that way so that states don't feel such the need to make those cuts. I will finish with the last slide that I included, I think it's still in the slide deck, some resources that include the fact sheets that I noted, but we also did some work nationally with the ARC and disability community to defend against these cuts that we think states could be implementing in light of budget shortfalls, but absolutely will do if they aren't at risk of losing federal funding because the maintenance of effort protections go away. So I will turn it back over to Melissa, who I think is going to give it over to Leo.
Thank you so much, Amber. And those resources are in this slide deck. They just are at the end. So I apologize for any confusion, but you will find them in this deck, and they are very, very useful. So now I'm going to turn it over to Leo from the National Health Law Program to walk us through the legal implications and advocacy strategy related to this interim final rule. Thanks so much, Leo.
Thanks. And can you hear me okay?
Can you hear me okay?
Sounds great.
Okay, great. Thank you, and good afternoon, everyone. I want to say thank you to Families USA for organizing this webinar and for inviting NHELP to join. I'm happy to take the baton here and run with it a little. If we can go to my next slide, please. I always like to start by reminding people that there are two things going on here, right? First, this reinterpretation of the maintenance of effort requirement, the MOE, is bad health policy. People will end up with worse health care or no health care. And second, it's also inconsistent with the law, right? So it's two things. And this slide shows a Venn diagram indicating that many, many policies implemented since 2017 are both bad health policy and not legal, right? This administration seems to have a gift for finding that sweet spot right in the middle. And so as I go through the next few slides, what I want you to focus on is, of course we're doing two things here. The legal side of the equation, right, that's our problem over at NHELP. Our lawyers have to figure out how to make that argument. But we need all of you to weigh in on the policy side of the equation. And as you'll see, that's not only important for proving the policy point, but also because it supports our legal case as well. Next slide, please. So Joe did a great job summarizing the reasons this new interim regulation will be harmful. What I want to do is just go a level deeper and give you a few examples, just so you start thinking about the concrete harm we're talking about. So for example, if we look at that second bullet on my list, one thing this regulation allows is for states to eliminate full benefits Medicaid coverage for some older adults. While those individuals should have Medicare, that doesn't cover numerous services that Medicaid may cover, from home health aid services to dental services, and it may have much higher costs. So a senior who ends up hospitalized due to COVID or any other reason may end up paying much higher bills without that Medicaid coverage. As another example, look at bullet 4. Joe discussed how the regulation would allow states to cut optional benefits, which is a huge problem. But in addition to that, it also allows them to cut the amount of all kinds of benefits. So for example, while a state must cover doctor visits, a state could try and put a cap on the number of doctor visits you could have in a year. Or some of the states that actually have such a cap already, let's say the state has a cap of 10 visits per year in place, they could try and lower that number to 5 or 4 or whatever. So imagine what that means for somebody with a chronic condition or with COVID symptoms, or even worse, with both, over the duration of a whole year. And remember, what we are talking about here is a state doing that, but still claiming the extra stimulus money, despite the fact that the law says, and Congress intended, that they have to maintain their effort for eligibility and benefits to be able to get that extra money, right? This is giving states more money with nothing in return. Just one last example. Look at bullet 6. Let's remember, this regulation doesn't just open the door to services cuts. It also allows terminations. For example, CMS generally interprets the MOE to require continued coverage of women after their postpartum period ends after labor and delivery. But surprise, surprise, for a subcategory of immigrant women, this regulation says, you know what, their coverage gets terminated. The federal maintenance of effort law says nothing about that. They just made this up over at CMS, and it will harm immigrant communities that are disproportionately impacted by COVID, right? So the bottom line I want you to take away is this is not an academic argument we're having here. These policies are going to hurt real people, and so we have to stop it. Next slide, please. So what can you do? Well, I loved Amber's summary of different ways you can mobilize at the state level, either preemptively or in response to cuts. So I don't need to say much more about that. I'm not a comms expert, but I think cutting health care during a pandemic, during an employment crisis, when people need health care and jobs, and this is what they're doing, I think there's a lot of public messaging room for you to run with there. Second, it's really important that you report any state-level cuts or violations that you see regarding the MOE in your state or a state to us at NHELP, to families, to Justice and Aging, and other partners. I can tell you on our end, for example, if one day we decide to file litigation, we need plaintiffs to do that. We need to be able to tell the story of people who are impacted. So we need to know what's happening in what states so that we can find the right plaintiffs. So please, if you see cuts happening, let us know about them. Third, if you have any role in federal legislation or influencing reps or senators in your state, we need to make sure that if they pass more COVID legislation, they fix the problem that CMS is creating here and certainly don't make it worse. Fourth, you can file a public comment between now and January 4th. And I'm going to talk to you more about that now, but I want you to understand that that is another important way that you can fight back. So next slide, please. Before an agency can finalize a regulation like this one, they must provide public notice of a proposed regulation and an open comment period where they accept public comments, which they must consider before finalizing the regulation. And to be clear, this is much more than just sharing your story, right? Because the comment becomes part of the formal administrative record. And why is that important? I'm going to highlight 3 reasons, right? The first is this current administration will be on the record as finalizing a terrible policy, and they can't deny knowledge of the problems that you raise in your comments. We don't expect them to do the right thing, given their track record, but it puts blood on their hands for everyone to see. And as a side note, since they also have to read all the comments, the more of you that file comments, the more time it takes them, and they don't have a lot of time left. Second, this is the formal record that the Biden administration will look at. Your comments become part of that formal record. And if, let's say, the Biden administration decides that they want to review whether this terrible interpretation should be reversed, your comments give them the information they need to evaluate that and the justification for fixing the policy. That's a justification politically, in the court of public opinion. It's legally helpful to them. And of course, speaking legally, third, if one day we decided to file litigation, your comments are part of the evidentiary record that we rely on. For those of you who haven't seen how this is played out in the work requirement cases, we have won all of those cases. And in the most important decision at the Court of Appeals, in the most important paragraph of that decision, the judges specifically cite the overwhelming evidence in the comments proving the policy was harmful. And a lot of that was thanks to organizations working with Families USA and their incredible network. So we are so grateful to all of you for what you do. So in terms of litigation on this MOE policy, there's no decision as to whether we're going to file litigation, and if so, when we would file it. As you can imagine, the situation is pretty fluid right now, and we don't like to get into kind of speculating about litigation. But there are a lot of problems with this regulation. First, there are the numerous, and I mean numerous, features of it that have no basis in the law and in fact conflict with the law. Remember, a regulation is supposed to interpret the law, not change the law. In addition, remember, as Joe discussed, they actually got this policy right for like 6 months. They issued multiple guidances interpreting it correctly, and now they're pulling a 180 and changing their policy. That raises legal issues. This is also a really consequential policy. And instead of doing this notice and comment and then implementing the final version, they're doing it as interim final, as Joe described, meaning they implement it before going through the notice and comment process. I mean, that is literally shooting first and asking questions later. And that's something that you're only supposed to do, legally speaking, if there is some overriding important reason. So that's another legal concern. So in addition to being bad health policy, this regulation that they've proposed also raises serious legal issues. Next slide, please. This slide just covers what types of things you can put into comments. And let me just say at the outset, different commenters have different resources available to them. And so based on that, you can aim for pie-in-the-sky comments or bare-boned comments. The most important thing is file something, right? Something is better than nothing. In a minute, I'll talk about some resources we have for you. But typically, we recommend sort of this list. Tell HHS who you are and why you have expertise, right? If you're on this call, you have expertise. Maybe you're an expert on the challenges West Virginians face in using their health insurance. Or maybe you're a consumer who has a chronic health condition, and you're knowledgeable about what consumers with that chronic health condition have to do to manage that condition day in and day out. Explain your expertise. Explain that. Tell HHS why it's bad policy. Explain the impact on you or the clients you work with. If you can, cite to any studies or data or other evidence that helps prove your point. Explain what you know based on your experience. Add as much original content as you can, whatever your time and resources permit. And our final cardinal rule is do not tell HHS how to improve the bad policy. Tell them to reject it. Don't say to HHS, hey, this policy would be okay if you did X, or the one problem with this policy is Y. Because they might fix one tiny little thing, still leaving us with a terrible policy, but later claim to a judge, hey, we took the advice of these advocates. So don't make your comment about solving the problem for one population. Make your comment about using the examples of your population as examples of why the answer to this policy is no, no, no. Your advice is don't do this at all. Next slide, please. On this slide, you just have some resources that we have to support your commenting. We have a template comment that will be circulated maybe today, if not tomorrow, just to give you a sense. That template is probably a great fit for a smaller sized organization that doesn't quite have the resources to write their own comments from scratch. There will also be some population-specific templates next week. One focusing on disability and aging, one focusing on reproductive health, one focusing on issues facing communities that are Black, Indigenous, and people of color, maybe a couple of others. Those are great for organizations that specialize in one of those areas. The templates are probably a bit much for many consumers who are totally new to all of this. And so if you are such a consumer or you work with them, I also can recommend our portal, which is called My Care Counts, and I'll share a screenshot in a minute. I also added a couple links here. One is to a social media toolkit we have, and one is to a fact sheet on commenting that sort of summarizes some of the points I've made here today, in case you want to refer back to them. And to my last slide, please. This last slide has a screenshot of the portal I mentioned, My Care Counts. It has a simple interface for someone to enter their name and email and takes them to a pre-populated comment which they can click to file. It's analogous to signing an online petition. So hopefully these resources can help us run up the score against the administration in terms of comments on this regulation, and that will one way or another help us sink this bad regulation. Thank you so much for your time today.
Thank you so much, Leo. We really appreciate you going through that with us. And so I am just briefly going to recap, and Leo covered this in depth, so I'm going to recap where we go from here and some of the resources we have at our disposal, and then I'll open it up for questions. So in terms of what we need to do as a community, it is time to act in response to this interim final rule, and there is a real multi-layer approach here. As Leo was just talking about, the immediate opportunity is to submit comments on this rule before January 4th, which you can do using those wonderful templates that will be coming out from NHELP shortly, or through the portal that Leo just mentioned to you all. The next piece of this is making sure that the Biden transition team understand, and the incoming Biden administration, once they're in seat, understand the implications of this rule and understand that rescinding this should be part of their priorities, or responding to it, so that they are helping people get the care they need, not preventing them from doing so. The third piece of this, as we discussed earlier, is congressional advocacy, making sure that the incoming Congress understands that any COVID-19 relief legislation must include another increase in FMAP in the federal funding for state Medicaid programs. And to get that federal funding, there need to be robust maintenance of effort protections that include optional benefits and some of the other things that are being pulled back in this final rule, or interim final rule. And then finally, very important to be tracking this on the state level, doing state advocacy, pushing to prevent Medicaid cuts, particularly for newly allowed benefit cuts or options to add cost sharing or other, challenges and problems. And as Leo said, it's really, really helpful if you all report any state level cuts or violations to national organizations like NHELP and Families USA. It really bolsters our collective advocacy and our ability to respond. And so now I will briefly show you all resources that are available. We talked about many of these today, and I won't go through them all right now since you've heard about all of these from our fabulous speakers, but these will be in the slides that come around, and we hope that you'll use them to your advantage. We'll also make sure that you all get the template and the portal that Leo mentioned. So now I'm going to open it up for questions. We've gotten a number of them in the chat, but feel free to keep them coming. And I will go ahead and start reading these to our presenters so that they can respond to your inquiries. All right. So first, we have one that says, can you explain how presumptive eligibility is not considered validly enrolled?
I can start and then see if Leo or Amber want to add in. In the regulation, CMS is justifying it by saying that they've not received a full determination of eligibility, and so that that's really all that it says, and there's no more discussion beyond that. So that's really all there is there. I don't know, Leo or Amber, if you want to add any additional color or context to that.
This is Leo. That's probably in my bailiwick. So as Joe described it is right. So I think there are a couple of points about this. They just are taking the position that, hey, if somebody is made presumptively eligible, there hasn't yet been a full determination of their eligibility, and therefore they don't actually count as somebody who is officially enrolled. And so if that person, that person's coverage doesn't get protection until they get that kind of final determination level. There are a couple of problems with their interpretation. The first one is that actually in the statute it uses language, when talking about presumptive eligibility, it uses the language determining on the basis of preliminary information whether someone is eligible under the state plan. So the actual language of the law on presumptive eligibility doesn't match the way they've characterized it in the reg. So that's like a technical legal point, but I think it's important. The other thing is just in general, CMS, one of the things that what they say in this regulation is, hey, or one of their approaches is to say, hey, if somebody has filled out, if somebody has failed to respond, somebody who is eligible has failed to respond to a contact from their state agency, that's not sufficient grounds to terminate them. So, our argument is this presumptive eligibility should have the same policy. If somebody has gone through the presumptive eligibility process and just has failed to follow up and submit document X, that shouldn't be the basis for cutting them off. The basis for cutting them off should come when you review document X and you conclude that actually this person was never eligible for Medicaid. And if you get to that conclusion, then yes, consistent with the policy, it might make sense to not continue their coverage. But until you actually know that, you may have a person who's eligible and just hasn't given you a piece of information, and that's just like the same policy in other situations where somebody who is eligible hasn't given you something. So we think based on the law and consistency, that's why they're wrong on that policy. And the template mentions that.
Great, thank you. So the next question we're seeing coming in is, are states likely to move forward with cuts in coverage over the next couple of months, or will they wait to see if the Biden administration reverses the policy? And I think we'll go to Amber first for this one.
Yeah, it's a great question. I think because of the uncertainty and the administrative complexity that comes with this complete reversal of the MOE protections, that a lot of states may move forward. That said, that's why it's so important that if you're hearing on the ground information about cuts, that you're reporting it up so that we kind of have a better sense of what's happening on the ground in states. I don't know if anybody else wants to add to that, but that's my take.
I agree with Amber, and I think you can use this as part of your advocacy pitch, right? Which is, hey, to your state people, which is, hey, don't change this policy. I mean, Biden's going to come in and change it anyway, and there's a COVID crisis going on, and NHELP might litigate this, and the people who did work requirements, they got sued, and the states spent all of this time and effort to do work requirements, and they never were able to do it, or their work requirements got cut off. So don't waste your time, state. Don't waste your time trying to do these kind of cuts.
That's great. And the one other thing I just will add is, they aren't likely to wait and see, but I think it is a good talking point. However, we as an advocacy community do need to make sure that the Biden administration feels pressure to reverse this policy, as state policymakers, for the most part, prefer to have more flexibility and may not want to see this reversed. So next question. For advocates and lawyers, is anyone litigating Medicaid maintenance of effort in, say, state fair hearings?
This is Amber. This question is kind of unclear to me, but there are state fair hearings taking place when states have not properly implemented the protections under the maintenance of effort. So if the states weren't previously following the guidance like they should have been, advocates have been using that guidance to say that these cuts should not have happened pursuant to the maintenance of effort protections. So that is happening at the state level.
Okay. Another question. If a state advocate in a state with serious budget problems was to recommend alternatives to cutting Medicaid, are there resources or recommendations for other revenue sources that would be better budget alternatives than cuts that would cause the state to lose federal matching funds, or not? But for example, information on advocating for provider taxes.
This is Amber. In California, there's a campaign called Commit to Equity, which is based, that it's kind of to this question that the whole point was to raise revenue to prevent cuts. So as California is losing revenue, what are ways that we can increase revenue at the state level? So the campaign has some certain tenets, and you can look that up online, and I think it's committoequity.org. I don't know if others have ideas about other ways that states can generate revenue or offset budget deficits with other solutions.
Yeah,
this is Leo. Oh, go ahead, Joe.
You go first, Leo.
So I think, this is an issue that comes up kind of every time we have an economic picture that's, recession or recession-like. So we have the documents that we sort of update every time this happens about other ways you can address costs. I think in the context of this MOE, if it's coming up in the context of this MOE, I think it's really important to start with the premise that what we're talking about here is what you do for the extra money you're getting to help fill in the hole, right? So this is the extra money that is designed to fill in that hole that states are dealing with, which doesn't mean that states don't have a problem. It's just, the extra money to fill in that hole. Second point is we want to be really careful while we do suggest win-win ways to gain revenue. We don't want to say, do this and cut over there. We don't want to pit one population against each other. We don't want to pit healthcare against, education, because that is not a long win-win strategy for us. Certainly something like provider taxes, to the extent they're available, might be a way to raise revenue. So there are ways to raise revenue, and creative thinking can get to some of those instead of the options we don't want.
Yeah, I think that's a great point. The only other thing I would add is just to think about some of the other places around affordability, surprise medical bills, prescription drug places that have some opportunity for offsets, but also a place that has gotten a lot of traction is around opportunities in the justice involved space, a lot of opportunities with federal dollars that can take pressure off of state and local budgets. Not always the biggest dollar savings, but some opportunities there as well. So, every little bit helps.
This is Amber again. Building off of what Joe just said is, of course, this has been mentioned throughout, is continued pressure on your state legislators or federal legislators to increase the federal match for Medicaid and to maintain those robust maintenance of effort protections and any FMAP increase. So you've got the Families First increase. I think in the COVID relief packages, there have been multiple pushes to do another increase of the FMAP and also a specific increase for home and community-based services. So I think we need to keep the pressure on our electeds to ask for that federal funding, again, to take off the pressure on state budgets.
Great. I'm going to ask just one more question to close us out. Is the part of the rule talking about states deciding or states being allowed to disenroll people who are not validly enrolled, or being able to move people between eligibility categories or off of eligibility categories, is that mandatory, or can a state still claim the enhanced FMAP if they decide not to disenroll people who are technically, quote unquote, not validly enrolled, or decide not to move people between eligibility categories? And I apologize for stumbling over my words there, but hopefully that was clear.
Yeah, unfortunately, this is Leo. Unfortunately, your question was clear because it's a very hard question to answer. there's not one broad brush answer I can give you in terms of when we looked through the regulation of it always means that the state can't pay for it, or it always means the state could pay for it if it wanted to. It seems to vary depending on the section. There are sections where it's phrased really, it seems like it's phrased really clearly. So for example, the example I gave about the pregnant immigrant women, that seems really clear that they're saying you can't pay for it even if you want to. And so that if you extended the coverage of those immigrant women, you would not get you would not be able to get any match at all. There are other places where it's much less clear what would happen if a state wanted to continue this coverage and then tried to request matching funds. So I haven't taken a totally scorched earth view on that interpretation yet, but it's definitely a potential issue. I don't know if others have looked at that.
Great.
That's my understanding too, Leah.
Go ahead.
No, I was just affirming that was our understanding as well.
All right, well, I know we are just about a minute over time, so I'm going to go ahead and close this out. But thank you all for joining us today for this great discussion, and a special thank you to our speakers today for sharing all of their expertise and knowledge and insights. And we will be in touch with additional resources and opportunities to take action. Thank you.